meeting the needs of communities and the needs on the ground. We also had a very large digital media and communications component, which I will talk about later in the presentation. Another thing about the ECAP program that was unique during the Ebola response was that we did operate in all 15 counties of Liberia, which, if you know Liberia, is no small feat. So go to the next slide. If you can go to the next slide, please.
Sorry, Sophie, a bit of a delay.
Okay, so to understand the different technology we used, I think it's important that people can understand the way the program operated, because we had different pieces of technology targeting different people within the program. So MercyCorps itself, along with PSI, provided training to around 900 partner staff members. So these were the people working on the ground doing the work. We provide training in terms of the messaging, behavior change, M&E system, and also we provided a LG smartphone to each of these 900 individuals. This phone was used for data collection and also for engaging with the other technological aspects of the program. And these phones were donated by the Paul Allen Foundation through NetHope. Now, these partner staff members then went on to train 15,000 individuals in communities to do the messaging. And it was the staff members that were supervising these community members in the messaging. So it was a cascade system, and the different technology targeted different individuals within the cascade. So if you go to the next slide. So within ECAP, we use quite a number of different types of technology, with the idea being that by using all these different types together, they would create quite a strong platform. So first of all, we had an ECAP Facebook page. This may sound not very exciting, but given that we were such a big network of 77 NGOs, we needed to build some momentum around the network. And the Facebook page, particularly in Liberia, where people are quite active on Facebook, was a great way of getting individuals within our partners to engage in what they were doing and share information. Additionally, we had a website which shared information on the research we had done, updates in the epidemic, the data, and other information that partners needed to know, including the different things partners were doing. This website was open to the public, with the idea being it would improve coordination. On the website, partners and anyone could see exactly where we were working, what communities, what districts, and the type of work we were doing within each of those communities. We also distributed audio and video content on each of the mobile phones that were distributed across the country to the partner staff members. These audio and video content was intended to be used to refresh the training materials of those managing the social mobilizers, and also to engage difficult individuals within communities on challenging topics. So for example, for something like stigma, if someone's working sort of in an area where there hasn't been any Ebola survivors, you could use the video content to try and get people to really understand why we're talking about the topic and relate to it in a better way. We also established an SMS platform targeting those community level people at the bottom level of the cascade who did not have smartphones. This was done using the Rapid Pro system under UNICEF. In addition to this, we had WhatsApp groups for all the individuals with smartphones, and these groups were for peer-to-peer learning and sharing stories and experiences. And finally, we also had a large-scale digital data collection component where we were collecting 15,000 knowledge, attitude, practice surveys every month from across the country and sharing those results with anyone and everyone who was interested through the website. Now, the main aim of sort of this discussion today is not just to talk about what we use, but to talk about what actually worked. And I would like to be realistic here and let you know that not all of these different technologies worked. So if we can go to the next slide, I'd like to sort of work out, inform you on what we think worked well and what really didn't work well. And as was mentioned in the introduction, obviously a big issue was connectivity. For a lot of the internet-based systems, you had people in the southeast of Liberia couldn't really connect, and it really didn't work. Our website was not accessible to them and they couldn't engage. With our SMS system, it failed. I can't say it in any other way. We had a lot of issues with the network providers here in Liberia. We couldn't get contracts, we couldn't get the system up and running. And so after 1 month, we disbanded it. With some of the phone-based systems, so the audio and video content, the data collection, the WhatsApp, we had a lot of challenges with troubleshooting, particularly with people in the Southeast. Over time, we developed ways to respond to this, but at the beginning, for the first few months, we really struggled. So when a phone went down, it was down, and there was no way of fixing it. The other big challenge for this was it was a major time and staff investment from the MercyCorps level. And I think that is something to think about in future epidemics, whether this is actually worth the time and staff level of investment. But despite talking about the negatives, there were still many strengths. So things like the website and the WhatsApp group were fantastic for creating peer-to-peer learning networks, which really enhanced the social mobilization that was occurring at the community level. And I think for the Ebola epidemic here in Liberia, this was what was really needed, with people, young people learning from other young people on how to best inform their communities. And that was something we couldn't have established without using technology. It also really encouraged staff to work a bit harder. So, for example, when you have people that have to travel 3 or 4 days to get to a very remote community, a lot of them are not eager to do that. But by knowing that they could share the photos of what they'd done, talk about what they'd done on the WhatsApp group, people were willing to go the extra mile to go to those far, far remote communities, because they knew that they had a big network around them that was supporting them and encouraging them to do the work. So for us, that made a big difference. Additionally, another major strength was our ability to share information from MercyCorps down and from partners up, particularly with those in the Southeast where it's very hard to communicate. Sometimes phone networks don't even work. When the internet system was working, the website and the phones were a fantastic way to get information to them fast and to respond real time. This was particularly important with issues of community entry, where someone could message on WhatsApp and say, we're having an issue, and we could send a staff member there straight away, or we could call, which was more reliable than some of the text messages where you didn't know if it had gone through or not. So I think this gives you an idea of what worked well and where we had challenges. And I don't want to go over time, so if you can go to the next slide, I'll go through the main lessons learned. So I know this is emergencies, so I talk about a lot of this stuff involves planning and time, so it's not always possible, but I'm going to say them anyway. The one thing, I think the main thing we learned is that having the right team to set up these systems is really important. If you don't have the right people that know IT, that know how to troubleshoot, that know how to make systems more flexible from the back end, there's no way it will work. And so investing in the right team at the beginning is really important. The other thing is investing time in training. If you want people to engage in technology, they need to know how to use it. But something like WhatsApp, that was very easy to use once we had the system set up. But as soon as there was any flaw in the system, there was no way to repair it. So investing time in training people in how to fix things. Planning obviously is not easy to do in an emergency, but there are certain things you can do. In a week's time, you can plan a bit more than what we did. We should have done a bit more research about making plan Bs for our SMS system that we didn't do. We could have gone back to a very low-tech SMS system, but because we hadn't even thought of it, we kept pushing for this complex system and it never really eventuated. So I guess all in all, the big lessons I think we learned from our program is, making sure you think through what you use and make sure the technology is appropriate for the country that you're working in. But if you do that, I think it can have a fantastic impact on something like the Ebola epidemic. I know that our use of technology really made our program much better, much more enhanced, and I think the impact was actually felt at the community level. But again, it requires a lot of time and investment. I think that's the main things. I've seen in the question bar, someone says that I said that the SMS system was difficult. I think this is something that I'm not sure is an issue in all countries, but in Liberia with the network providers here, Lone Star and Cellcom, we had a lot of trouble establishing, basically, they agreed to the system, but then they didn't actually implement it. We also had some issues with the Rapid Pro system that UNICEF had set up, but I think since now, I think UNICEF has worked on fixing that. I know that other partners such as IntraHealth, I think, are using Rapid Pro at the moment, and it works fine, but during the emergency period, it didn't work. There's another question about the Facebook page. The Facebook page was, I guess it goes back to what I was saying, where all this stuff on its own, I don't think is that effective, but as a package, it worked quite well. So a lot of the social mobilizers that we worked with were young people who were very active on Facebook. So they used the Facebook page to share photos and videos, and then to sort of talk about the successes of the program. And we used it as a way, we had competitions like, best social mobilizer of the week, and we sent out prizes. And so it was a way to sort of motivate people and build sort of a momentum around the network and the work that was doing. I don't think the Facebook page on its own would have been effective, but I think in combination with the WhatsApp group where we could advertise it and share it, it worked well. The Facebook page is actually still active because we have a second program called ECAP2 with a lot of the same NGOs. So we're just continuing to use the same Facebook page. I'm seeing another question, which is about combining data from the multiple sources to get a good overview. So a lot of this basically requires a strong team at the back end. So that means the people that are managing the WhatsApp and the Facebook are sharing information with me, who is managing the monitoring and evaluation system, who's also sharing all this information with the team that's working most closely with the partners. I think we didn't do this as well as we could have, but I really think it comes down to sort of meetings and communication within the back-end team. And I know that for the new program we're working on, we're using some of the same systems and we've actually improved, but it really comes down to, sounds really basic, but meetings, team meetings, sharing the information, and then trying to make the website as a hub for all the information. So a lot of the comments coming from the WhatsApp was loaded up onto the website. The data is loaded up to the website. So trying to link them all together. But I think it's a good point and it is a challenge. But I think that's for me, that's everything unless anyone has any other questions. Adele is saying she has a question. Okay, I'm seeing Adele's question, which is that the work required a major time and staff investment. What I mean by this is, so our program was quite expat heavy during the outbreak. So we had a special guy running the digital system. We had someone doing mass media, another expat. I was on the M&E side of things. And as everyone knows, during the Ebola outbreak, you work non-stop. Not all programs have the opportunity to invest this heavily in expats. And there's not a capacity at the national level to run some of these systems. The SMS system could be run and some of the WhatsApp groups could be run, but the initial setup process required the right team. And when we had challenges or we needed to adapt or troubleshoot, you really needed to have people that understood the technology so that they could adapt them. Yeah, that's what I mean by you have to invest the right system. The other thing is, like for me, from my end, with our large data collection component, it was so big that we didn't really have enough time to probably use the data and engage with it as much as we did actually collecting it, which is a big weakness of the system. So you just have to be willing to realize that these systems are not easy things that people can run and that it will take a lot of time to make them run properly. I guess my view is if you try and do something 50%, you may as well not do it at all. You have to really try very hard to make it a robust system because a lot of this tech stuff is it fails very easily. So unless you're willing to constantly fix the challenges that come up, it won't work well. I'm seeing more comments. With the staff training, I said that we did do training, but it wasn't enough. So we did a lot of training with the NGO staff, but again, we were working with about 1,000 staff we were training across the whole country. So for us to do a training with staff, it took a lot of time. And so I think we did 3 different training rounds over the period, and even that, it wasn't enough. So it's not that staff training is not worth it. but it's quite time intensive and you need to invest a lot of time in it.
And Sophie, you have just a minute or two left in this section, and then we'll head on to the next presentation.
Yeah, I'm seeing from Mark that the plan B for low connectivity was SMS. Definitely, that was the plan B, but the plan B failed, sadly. I think we've set up an SMS system now for the new program, and we know better how to do it. I think our failure was maybe to engage more with the current systems in Liberia, see what people were using. We just went with the rapid pro system, which at the time wasn't functioning well, but like I said, I think right now it's functioning quite well. Just our experience wasn't that positive. In regards to WhatsApp in the rural areas, WhatsApp didn't work in the rural areas, but some people went to the towns. So for everyone to submit data on the mail system, they had to come to town to submit the data. And so often they had internet then, and they engaged in WhatsApp then. So even in the rural areas where there wasn't high levels of connectivity, there was an engagement with WhatsApp. The big problem in the rural areas was that when WhatsApp updated, which WhatsApp does because it's application, it doesn't update very well in Liberia because they don't have an agreement with Liberia. So you had to manually update it, and we couldn't fix that when people were in very remote areas. We didn't have enough staff to be able to go fix and troubleshoot all these phones. And I guess with Elizabeth, I guess you're right that it is an important investment of staff time. And I do think, like I said, I think our system was worth it. But my worry is that in future epidemics, people will, again, try and use all these tech components, but maybe don't allocate staff or resources to them. And so then the systems don't work. So I think if you wanted to make it less staff intensive, you have to use technology that local staff or national staff can work on and can adapt, and that that Liberians can troubleshoot. So for example, with the WhatsApp, people couldn't work out how to troubleshoot when they needed to update. So there's also other ways of working around it. For example, we made videos and PDFs of how to fix problems and sent them out onto all the tablets, on all the phones. And that was a way of reducing the time on staff, the time burden, but even then it's still quite a heavy burden.
Thanks a lot, Sophie. Yeah, thanks very much. I'm sure everyone is clapping on mute. And it's great to hear both the positive effects as well as a good dose of realism about just how hard it is to implement and maintain these systems. We certainly resonates a lot with us as well. So I think we'll shift on to the next presentation.
Yep. So we're going to transition over to Jean-Martin Bauer's presentation from World Food Program. So Jean-Martin leads the Mobile Vulnerability Analysis and Mapping Project. His recent work focuses on using new technology to track food insecurity areas that are too dangerous for face-to-face data collection. Jean-Martin has worked on using text message, robocalls, and voice surveys to reach out to crisis-affected communities in Africa and the Middle East. He has also worked on using cell phone metadata to estimate population movements at times of crises.
Just 1 second while we switch over to that second PowerPoint. And Lucia, we'll unmute you as well. Yep.
Hi everyone, can you hear me?
Yeah, we can hear you great.
Great, so this is Jean-Martin. I'm calling in from Rome. Good morning to you all. And I'm gonna have a few minutes to tell you about the Mobile Vulnerability Analysis and Mapping Project. So the Mobile Vulnerability Analysis and Mapping is about reaching out to people using the phones that they already have through SMS, interactive voice response, in order to inform WFP's food security responses. If I could go to the next slide, please, and show you a little bit more about what part of WFP I work for. Right, so I work for the WFP Food Security Analysis Unit. What you see here is the way our website looks. We have a network of 150 analysts worldwide whose job it is to track food insecurity. We do things like baseline food security assessments with national governments. We do monitoring systems. We do market analysis. We also have some work on nutrition. We also have a commitment to providing public goods and a commitment to open data. You can find a lot of data sets and information on the website you see here. So what I want to do today is give you an overview of the mobile VAM project and how we use it for Ebola. So VAM was actually, next slide please, the VAM department, the Food Security Analysis Department at WFP was created in 1994, quite some time ago. We're actually proud to work on new technologies when they come out. Really new things like geospatial. We were into doing that in the 1980s, and then when PDAs came out, of course, they sound really antiquated now, but we were among the first to use them, and we're proud of that. What I want to tell you a little bit more about today is how we're using mobile phones for food security needs assessments. So the MVAM involves contacting people through their mobile phones, the feature phones that they have. So no smartphones, no data plans, really the basic phones. And which actually are the ones that people use in places like Liberia, Guinea, or Sierra Leone. And we contact them in one of three ways. So either interactive voice response. We've used Instead's Vervoice, free and open source software to run our interactive voice response calls. We've had operators call people up. And we've used a lot of SMS surveys, and SMS ended up being our main tool for Ebola. The idea here is to reach out to a large sample of the population, ask food security questions through text messages, aggregate that data in a data aggregation backend. I'll tell you a bit more about that. That information is used in order to inform the humanitarian decision-making process. So in terms of resource allocation or advocacy. And the advantage that we have with MVAM is essentially threefold. It's much cheaper than doing face-to-face surveys. It's faster than other types of surveys in terms of survey turnaround time. And it's also safer for our staff and cheaper. We usually get an SMS questionnaire done between $3 and $5 per complete. Faster because an SMS round for 1,000 to 2,000 households will take us 1 to 2 weeks instead of 4 to 6 weeks when we send out the enumerators. And it's safer because in a case like Ebola, you'll remember that it was very difficult to send people out to the field, and we were able to access all of Sierra Leone, all of Liberia, of course, cell phone coverage permitting, but it was actually quite widespread, and all of Guinea, thanks to the phone survey. So those are the advantages of the tool. Next slide, please. And what you'll see on the next slide is, in fact, our strategy in Guinea, Liberia, and Sierra Leone. We're a place we first rolled out to after having a very limited pilot in DRC and Somalia. And the limited pilots allowed us to produce enough learning for us to be able to deploy very quickly when the emergency was declared for Ebola. Next slide, please. The learnings we drew from our experience with Ebola, with the automated SMS surveys, you'll see them there. So of course they're safer. I told you they're safer, they're quicker, and they're cheaper than the traditional face-to-face surveys. But I'd like to focus on the issues that came up. So of course there are biases because of literacy and ownership. Cell phone coverage and access to cell phones is incomplete in Guinea, Sierra Leone, and Liberia. I think we have about between 40 and 60 lines per 100 people. So there is a skew towards urban areas, towards better off households, towards young men. So it's a bias that's there that we have to deal with. One of the challenges was dealing with the volume of data. We're getting thousands of surveys every month, and that led us very quickly to have to work on automating the processing of the data. We also realized that SMS was not suited for longer and more complex questions. We found out that with short and simple questions, we were able to get good answers. So it was short and simple questions that require short and simple answers, and that's what ended up working for us. Next slide, please. The next slide shows you what we actually did. So 3 countries, I think we've got 12 rounds of data. out of the Ebola-affected countries. We began data collection in a matter of weeks after the emergency was declared, at least for WFP. It went through SMS. We had some IVR there. SMS worked better than IVR, by the way. And the indicators we collected by SMS included food security coping. So the strategies include, did you eat less preferred foods, or did you have to borrow money, or did you have to borrow food? So this is a standard food security indicator that's used worldwide. We had market prices, and we also asked people what they thought of food security in their community. That allowed us to produce the map you see here. We're able to track wage rates, as you see on the graph in this slide. We're also able to do word clouds and understand what people were talking about. And this was very new to us, we realized that people were very happy to engage with us by text message, and we got between 60 and 70% of respondents would text something in, and they'd say things like, oh, it's getting better because the harvest is coming, or the quarantine and the lockdown are preventing us from selling our food. That's how it went. The questions are asked of the general population. These are respondents that are randomly selected in each country. And we were able to go to do these word clouds, but also do a natural language processing and deploy natural language processing to assess the tone of the statements that were being made. And it was interesting to see that the tone of the conversation, you rated +1 to -1 according to an algorithm, was actually correlating quite well with the food security questions. So we were able to triangulate information that way. Next slide, please. So I'm now moving to lessons learned, and I mean, we thought it worked pretty well to get reliable, frequent data. Reliable in terms of the trends. We don't want to pretend that this was representative, but we got good trend data through thanks to SMS. SMS proved better than IVR. You get cleaner data by SMS, we think, because people are able to see the replies that they have before sending them in. When there's IVR, you don't have that much margin for error. The design of the questions is important. We had a lot of trouble with our questions initially, but I think after a few rounds, we were getting 95% clean data because we understood how to ask the questions. Engagement, I told you about the open question being a successful way to engage with people. And finally, perhaps on creativity, it was, we actually had to ask people, what kind of toilet do you have? And that goes back to the bias issues. People are saying, well, you're only reaching the richer part of the population, but in fact, we asked people, what kind of toilet do you use? And that allowed us to zoom in on the poorest households that replied that they had either a dirt toilet or no toilet at all. And we're able to monitor trends through time. And it was interesting to see much worse indicators and very different trends for that part of the population. And we were therefore able to produce information that spoke to people's needs. So finally, next slide, please. This is not something WFP did on its own. We had a lot of people backing us up on methodology. We had the Nielsen company helping us out. Tulane University produced an evaluation of what we did. It's posted online if you want to check it out. The tech that we used came from Instead for voice. I already talked about that. The surveys were done by Geopol. The SMS actually worked quite well in Liberia and Sierra Leone in our experience. We got very quick, we got the volumes we needed and the data we needed in time, thanks to Geopol. And we had contributions from the Humanitarian Innovation Fund, Google.org, Cisco, CSR, and USAID to make all of this happen. Final slide shows you links you might want to check out. The final slide shows you that we actually wrote an article that was published in the Overseas Development Institute Humanitarian Exchange on our experience with SMS and early warning for food security and Ebola. There are a few other articles you can check out there. If you're generally interested in the project, we have a blog that's available at mvam.org and our Twitter account at mobilevam. Thank you for listening. Over. So we had that question about Ebola patients or their families. What we did was ask questions to the general population. So these were randomly selected respondents, and they would get the survey every month. We had a monthly frequency, and we did everything we could to maintain a panel in order to deliver trend data. As I was explaining, the quality of the data that we had wouldn't really allow us to have quantitative estimates, so we tried to track the same people and get an idea of the trends. And the trends were actually getting a lot better as this time went on. So about IVR and why it didn't work out. It didn't work out so well, and this is perhaps counterintuitive because you think with literacy it's better to go with IVR. But when you ask people to estimate something or provide a number, like the price of a bag of rice, you'll get mistakes, data entry mistakes. that people can't fix with IVR. People might feel rushed by the pace of the recording. People have to finish with the pound sign on their phone. So there are little things with IVR that aren't very user-friendly. We found that IVR probably rushed people into replying in the questionnaire. SMS, people can take it when they want. With IVR, by the way, you get an IVR phone call, you have to reply right away, or else you can't stop midway. SMS, you can take the question when you want. You can stop replying. You can go home and reply in the privacy of your own home. You can check your answers before sending them in, and it seems to us that the data quality was much superior by SMS than IVR, perhaps for that user friendliness factor.
And this is Neil. Am I right that a lot of your questions were open-ended or open text? Like you didn't sort of favor questions even via SMS, was like respond 1 if you're this, respond 2 if you're that, where like the response is always very structured? Was it more open-ended responses?
Well, we were able to use open-ended responses. We always had, so the questionnaire was very short. We had about 10 questions in the SMS questionnaire, so it would come as a chain of messages back and forth. The last one was an open question. And in SMS, it worked great because it was text, and we could read the text messages here in Rome days after they were sent to us and process them in the way I described. IVR would have been more challenging because then you have to deal with transcribing the messages from IVR to text, and then doing the processing I was mentioning. So SMS did have advantages from that point of view.
Looks like there's one
Feedback loops.
now.
Okay, so there's a question on feedback loops. So the data was shared on the WFP website. It's available on an open access basis. And that was actually one of the successes for us, is that other organizations used our data and relied on our data for their reports and their analysis of the Ebola situation. I can think of FuseNet, LSE in Sierra Leone have this program, an economics program that used our data as well. The European Union as well relied on the data that we were collecting for their own analysis. I think when we look at the website, of course, it's very much the UN agencies, the governments, the NGOs. Some universities came and downloaded the data that we were collecting in this way. So it was put online every month when we were done. We also posted the information on the Humanitarian Development Data Exchange, HDX. I'm not sure everyone's familiar with that, but it's a platform run by OCHA, or sister agency, and we entered into a partnership with OCHA to make sure that the data we were collecting through Ebola would be shared with the entire humanitarian community through this portal, HDX, Humanitarian Data Exchange. And with the people from whom the data was collected, that's more complicated. We're actually working on that in the project, not in the Ebola countries, but in DR Congo and Somalia, where the information we collect is put onto a server and people can call in to listen to strategic information. We have a bit more about that on the blog, and I'd encourage you to check that out.
It's a little over 1 minute left, so I think there's one more.
Okay, maybe one more question. So from Emily Nicholson, what platform did you use for developing and sending the SMS? So we work through Mobile Accord, and they have a service called Geopol that we had tested in the Democratic Republic of Congo. We determined that it worked out well for the coping questions that I described. So we thought, let's roll this out in Ebola, and it ended up working out pretty well. So it's not just the platform, it's that the questions we introduced for Ebola, some of them were different from the pilot experience we had, and getting those questions right actually took a lot of iteration. The prices on the food prices were a challenge because we have to get the unit of measurement right. We thought that everyone would know what a bag of rice cost. And I mean, I've worked in Liberia and Sierra Leone. That assumption was wrong. You have to ask for the cup of rice. And when we started asking for the cup and the micro retail price, we got very good data. Asking for prices of a bag or of rice or palm oil or anything else was complicated. So it was really getting the questions formulated in a way that was intelligible to the respondent that really took the most effort for us. Of course, the open-ended question, that's something we hadn't tested before, and Ebola was the opportunity for us to learn quite a lot. So the lessons we picked up in Ebola, we're now applying in places like Yemen, most recently Malawi. So that's how our experience with Ebola is also helping us get better information in other emergency contexts as well. Over to you.
Great, thanks so much. I think that's just the the end of the slot, yeah, it's really interesting to see how the different systems kind of had successes, with SMS, without SMS, and that there are places where it works well, places where it doesn't. And so on to the next presentation by IRC.
Thank you. So our next presentation is by Paul at IRC. Paul Amendola is a technical advisor for health information systems at the International Rescue Committee and is based in New York. He has designed and implemented data collection projects and epidemiology studies in developing sub-Saharan African and Asian countries, focusing on increasing data quality and analysis through data training, reviewing, and advising on information systems and database creation.
Paul, I'll unmute you right now. We'll pull that up. It's a key detail. There we go.
Okay, is that okay?
Yeah, that's great.
Okay, great. Okay, if we could go to the first slide, please. My name is Paul Amendola. I'm the technical advisor for health information systems for IRC. This slide's about sort of the context, what IRC was doing during the Ebola response. We already during the outbreak that began in early 2014, we were already operating programs in Sierra Leone, Liberia, Cote d'Ivoire, and Mali. During the outbreak, the health response had a number of different activities. Our main activities, though, were focused on 4 of the hardest hit counties in Sierra Leone and Liberia. We were providing support to 3 Ebola holding units in Sierra Leone and support to 1 hospital in Liberia. In addition, we were also equipping facilities for Ebola response and measuring the readiness. Next slide, please. So I want to focus on 3 ICT interventions. They might seem a little unrelated. They happened in different areas, but our lessons learned for them were similar and have been applied to other programs. The first project was an electronic medical record system for a treatment unit, and then a database and record system for a holding unit, and then our facility readiness assessments. Next slide, please. So IRC was planning to open Ebola treatment unit in Liberia. Our challenge there was to design a system to be able to move data between infected areas and non-infected areas. Paper wasn't working. There were a couple different ideas of that other groups were using of using whiteboards, just shouting over areas. We had a couple of weeks. We had about 6 weeks from before we had a treatment unit being deployed. So we were trying to design and deploy a tablet-based EMR. In the project, we were partnering with Vecna, using a Clinipack, and the EMR was looking at patient-level data, real-time data, and implementing decision support. Sorry, next slide, please. Oh, sorry. So the EMR. Sorry, back to the first EMR slide. Can we go back one? I'm sorry. So this was actually never deployed. The training was done. The software was developed. the hardware was procured and set up, but just sort of set up in time for the outbreak to be winding down. So the system was never actually used. Next slide, please. Okay. In 3 Ebola isolation units in Sierra Leone, we were using an Excel database to track patient triage, to track patient outcomes, and to report to the Ministry of Health. Ideally, the staff was spending a lot of time with their paper forms. There was low connectivity, so we couldn't have anything that was going to rely on internet connection. But they had access to a laptop that could be used in the triage area. It was a line listing of patient records and had automatic completion of all the MOH forms, and kept track of the number of patients in the ward, all of their cumulative data, all of the indicators they needed to track, both for program monitoring and for donor reports. Next slide, please. And then in Sierra Leone, we were head of a consortium of 13 NGOs that were implementing facility readiness assessments that were done at every facility in Sierra Leone at least once a month. We went through a couple different ideas, but we were able to deploy a couple of hundred mobile phones with a short questionnaire. At the time, we were using ODK that fed into a DHIS instance for partner tracking. Each partner had access to the mobile data and to the DHIS instance for reporting. And throughout all 3 projects, these were our 3 major lessons learned. So user-centered design, for each project, I can't sort of stress this one enough. For the EMR in Liberia, what was the first iterations were designed at headquarters with clinic staff. When it was actually deployed to the field, everything needed to be changed. It cost a lot of time, it cost a lot of money. Although the basic idea of the patient flow through the facility was the same, how the clinicians saw the benefit of the system was different than the headquarters staff had seen. For the Excel database, it was we ended up using Excel for the reason that we knew that the data was going to change a lot. We needed a system that would be familiar enough with the end users in the field to be able to adapt as indicators changed, as their treatments changed, and didn't need a lot of back-end and technical support. For the Sierra Leone facility assessment, paper system wasn't feasible. Again, the user-centered design, how the questionnaire was designed and then tested with the partners, and then introducing that earlier and testing with the end users earlier would have saved a lot of time. It was designed, the first stages were designed by IRC. but having more of a consortium input would have been beneficial. Second lesson learned, the standard ICT assessment. We've seen the same assessment components that need to be checked before implementing each project. Sort of as Sophie was saying, staffing, having the right staff profile in place for the project and having enough staff members for troubleshooting and for backstopping is essential. That's sort of our first checklist item before we deploy projects. And that's definitely a lesson learned from this experience. Other components for assessment we look for is if we're introducing a new technology or if the technology already exists. Sort of with the other two presentations said the same thing. If the existing technology is just being leveraged, there's a better chance of success. Making sure the data is going to be able to be used and accessed, looking at what the mobile coverage is and the power supply situation is. Will the phones be able to be charged? Will the tablets be able to be charged? Looking at logistics for what is the process to repair a mobile device? What is the process to replace a mobile device? And what are your data protection and evaluation needs? Just the need to make sure those assessments are done before any sort of ICT is introduced has been, again, one of our biggest lessons learned. But moving forward, having in emergencies like Ebola, having readily deployable systems that we know have been validated, that we know have been tested in certain situations, would be really beneficial. Even if the content or the questionnaires changed, having reliable ICT systems we can deploy at a shorter notice. It's something I think we're all trying to move forward with.
Great, Paul. And you have about 3 minutes left if there are some questions. And I don't know if you were ending, but I had one on your last point, which is I'm curious, like if those CliniPack systems are they now like ready to deploy? You've done all the work. Like the next time, could they just be pretty quick to deploy, or relevant to your point about user-centered design? If it was a new country, a new area, would you kind of have to start from scratch and have the same? Would there be a big challenge of getting it out fast enough?
I think the lessons learned from how we deploy would change, but they would have to be too much adaptation done. They were so Ebola specific in terms of even the clinical decision support that was programmed. But even having a baseline set of modules, even on the CliniPack, that could just be somewhat, tweaked for different contexts, would be really helpful the next time.
Do you by chance want to hazard a time lag? Like if a new crisis was starting today, and you were just starting to go to it, how many weeks or months till it's a reasonable amount of time for deployment? I don't mean to put you on the spot too much, but do you have a gut feel?
If the staffing was there, we're fairly used to the steps that would need to be done. Maybe 4 or 5 weeks, I think, for something at like a treatment unit.
Great. Well, that seems like a big advance compared to probably what it took this time. So that's a
right.
significant improvement.
Paul, looks like you have a question. What system of data collection was used in the ETU?
The ETU, it never actually was operable, but it was using the Vecna software on the Clinipack.
But then did you use ODK as well to collect data from that was from not ETUs, that was from clinics.
Right. That was from clinics. That was from the health facilities. And I think our decision to use non-open source software was timing. We had about 6 weeks before we were ready to deploy, and normally that the open source would be a sticking point. But there were so many. There was such a time crunch that it seemed like our best option. Yeah, we do. We have a ICT assessment checklist that we can share.
Super, and I think that puts us at about the end of the time slot. Thanks a lot, Paul. And great to add see a lot of common themes as well as some new perspectives. It seems like each presentation is doing that. So we are on to the next.
Great, thank you, Paul. So our next presenter is Meenal, who's a research scientist at IBM Research Africa. She studied at the University of Cambridge and has PhDs from the University of Cambridge in chemical engineering and biotechnology. She previously developed a bioethanol combined lantern and stove designed for use in rural India.
Meenal, give us just a moment and we will unmute you.
Okay, great. Can you hear me?
We can, thank you.
Excellent, great. So I work for IBM Research Africa. We're fairly new. The lab opened 2 years ago. We have a lab in Nairobi, one in Joburg, and there'll be one in West Africa coming up soon. And so we started working actually with Open Government Initiative following the Africa Summit in fall of last year. And Open Government Initiative, oh sorry, could you move to the next slide? OGI asked us if we could help them because one of the things they wanted to know was to try and understand how well the Ebola response was going from the point of view of citizens. So OGI's mandate is to provide open channels for communication between policymakers and citizens. And so we helped them to set up the 644 hotline, which allowed individuals to call or text in. The way it was set up was that the health messages were going out over radio, and then there was a message about 644 afterwards, and people could call or text in. And one of the key things was that we didn't constrain the type of response. So there was no survey-based response in this. This was just people calling in about anything they wanted to. For the calls, these were then transcribed by OGI call center volunteers, and then the SMSs came in through an SMS gateway. Once we got those, we then worked on writing some code for message categorization, which I'll talk about more in a second. And then the results were reported to OGI, and then they could go back to so OGI sits under the President's office in Sierra Leone, so they would then go back through the President's office to government to report on what they were finding. So if you could just move to the next slide. So this is an example of the results that we got during the first September lockdown. So we categorized based on what was coming in and also based on the regions. These are just the call data. And we got people calling and texting in about all sorts of things. So the sorts of things that we were expecting, things that directly related to Ebola, dead body, sick person, things like no soap, which were obviously messages that were conveyed over public health messaging on radio. But then we also got a lot of things that we weren't necessarily expecting, stuff about lack of utilities, compliments about how the response was going, information about volunteers, and then this doesn't have the other category on it, but then we also got a whole load of stuff that was just completely not related to Ebola, people just calling in about something completely unrelated. And so this was interesting because actually over time we started to see these categories change. So this is the first one, we see a lot of no sensitization. As time changed, you started to see the idea of non-compliance becoming more ubiquitous. People understood what the response was supposed to be and how, and they would report when somebody was not complying. So things like my neighbor's child is sick and they haven't called 117, or the burial team came, but then they were asking for a bribe. So this sort of stuff started to happen. We started to get less of the no sensitization. And it was interesting, but as you can see from the numbers, the call numbers volume was very small. The SMS volume was even smaller. This is for a lot of reasons. Maybe if we could move to the next slide. So we suspect this is for a lot of reasons for the SMS. So low literacy, if you look at the color shadings on the chart before, there was a lot of purple, which was Western, so Western urban, and not so as much from the other parts of the country. So we were definitely getting sampling bias from that. And it was hard to know how much OGI was being accepted. And one of the key problems for us was that none of the responses could be verified, and therefore it was hard to provide follow-up actions. If somebody says that there's a corrupt burial team, what do you do about that? How do you know if other people are reporting it from the same area? And so this system was useful at the time. It was built, I just saw somebody ask how quickly it was built. It was built very, very quickly within a few weeks. We got cooperation from Airtel, who set up the 117 shortcode, and we got some donation in kind from a Kenyan startup who provided the SMS gateway. And so it was really put together very, very quickly. And so following that, we learned quite a few things. One is that this message categorization problem is not trivial. We didn't have high enough volumes to do statistical analysis, but that's really what it needs to be able to categorize these messages on the fly. And actually the creation of categories is hard unless you include a human in the loop. And so the other thing is also the responses not being verified. So one of the things we started to do was to work with Humanitarian Data Exchange, who Jean-Martin mentioned earlier, to try and see what open data sets were available to be able to try and triangulate between different data sets and find how likely a report was to be true. And what this sort of made us completely pivot, because what we realized that actually there was a lot of data out there that was available, that was being made open. People like World Food Programme, UNICEF were making a lot of data open. It was just hard to use because it all existed in Excel files. And there was a mishmash of data, some geotagged, some not, different field names for the same thing. So things like date or admin unit would often be named differently as a field. They would often be formatted differently. And so it was actually hard to do the data triangulation that we had thought would be easy to begin with. So now, maybe if you could move to the next slide. So one of the things we were doing was mapping out how people were collecting data during the outbreak and trying to see how communication was happening in terms of information systems. So obviously people are communicating with the Ministry of Health, but how were systems being linked together? There is, I know, an arrow missing on this for some of the data going into DHIS2, but it was actually when we went to the ministry, it was very hard to retrieve that data off DHIS2 and reuse it again. And so if you could just move to the next slide. So given that the ministry is now working much more closely on their internal HIS systems, the one link that was still hard for the folks we spoke to in Sierra Leone, which was MercyCorps and UNICEF, was the fact that a lot of this data is still going to get lost. Anything that's survey-based that won't go into DHIS, but that you want to combine with the DHIS type data, facility assessments, indicators. So if you could just, next slide. So this is the system that we're now trying to build. So we've kept some of the citizen engagement in. Right now we're trying to decide if we do that on our own or use existing systems. We're most likely going to use existing systems, so the Social Mobilization Action Consortium, SMAC, or UReport, and we're just chatting to partners now about who's interested in what they want to do. And using the community mobilizers, so this is also to get around the huge sampling bias that we ended up with by trying to do direct contact. And then looking at how to build out natural language processing, that's what NLP stands for in this diagram, to be able to categorize these messages more effectively, start to look at sort of the more machine learning approaches to message categorization and really start to build those out, which is one of IBM's big research strengths is language processing. So we think if we can get hold of the data for that in a large enough quantity, we should be able to do that. And then the other thing that we're looking at is incorporating it with open data from humanitarian data exchange. And so one of the key things here is to try and show what is the value of making your data open. So for this, we're working specifically on health facility accessibility index. So trying to see if we have health facility assessments, can we now start to come up with a composite score for them to measure their accessibility or their readiness for an epidemic. And so we're doing this using a methodology initially similar to Wealth Index, and then looking at using slightly more refined techniques such as decision trees and some more complex regression models with decision trees as well, to be able to then come up with a score for facilities and their catchment areas on their accessibility. And then the last part of this is M surveillance. So this will most likely be working with Goal, who have I think it's ODK or Kobo Toolbox, surveillance tool for measles right now. And the idea of combining these three, so the citizen collected data, the surveillance data, and the humanitarian data exchange, is to try and provide a more holistic picture of what's going on. And then this visualization dashboard can be used by both partners and the Ministry of Health to get a quick overview. One of the things that we're really trying to do with this dashboard is to make it easy to use. So lots of people are using ODK, Kobo Toolbox, ComCare, all of these tools, which, given the way many of them are set up, still currently terminate in an Excel file. Or if they terminate in a server, being able to pull that into a backend system that makes it easy to visualize. So there are a few parts to this visualization dashboard. One is data cleaning. So we're doing a few things around, so we're doing, in terms of data cleaning, we're doing a few things around being able to put in a sort of coding list for geotagging. So for facilities, for example, you have the ministry's geotagged master list now, and for all the old data sets to be able to go back and geotag for the ones that haven't been yet. Also looking at things like deduplication of files. So we found, for example, one of the Sierra Leone schools files had one school entered 15 times with slightly different spelling, slightly different GPS coordinates. So building tools that will automatically do that cleaning. And then the other thing is making it really easy to upload both the tabular data, so CSV and Excel data, but also shape files, so map files. One of the things we really wanted to do was build some analytics off OpenStreetMaps around travel times to health facilities, and making it almost a drag and drop so that you can just put, so we have this set up right now for tabular data where you upload your tabular data file, hit integrate, the code at the back finds the geocoding column and will then pull all the geodata out and map it for you automatically. When you click on a point, it will then pull up all of the individual fields for that point that were collected in a survey or that were in that file. So the idea about this is really not to now collect new data, but just to work with the data that's there, help to triangulate it and make it easier to use. And the specific use case that we're working on, which is what this slide is now on right now, is from the community data to really try and understand the demand side barriers to accessing care. So what are the softer factors which often aren't included in quantitative models for healthcare accessibility? Looking at things like, why are people not, what is trust in the health system like? Do people think that they will get good service if they go? These sorts of questions. And then looking at the supply side, by looking at the facility assessment, seeing if this facility accessibility index will work, if it's representative of the reality. And then finally the surveillance, so looking at demand for care. And if we have these three, we want to see if the end user can start to identify what are the high risk areas. So we know where an outbreak is. We also know roughly how prepared it is from the accessibility index. And then we also know how open that community is from the community engagement for accessing care. So between these three, can we now start to see areas in which you may want to focus your community engagement, or maybe change the way in which you're targeting the messaging? Next slide.
And sorry to interrupt, you have about 3 minutes left.
Okay, sure. So this is the last slide. So this is just this is still a work in progress to build this platform out. This is the front end that we have right now. The health accessibility index, actually, as of today, will be updated with the new wealth index type accessibility index. And so we're just plugging the bits together. The project will run till July of next year, and it's now funded by USAID Ebola Grand Challenges. So that's sort of me done. I can take any questions for the last 2 minutes.
Great. And do you see a couple in the chat, or should we read them out?
Oh, right. Yeah. Yeah. So in terms of how long did it take to set up the original OGI system, that was the setting up the system. The biggest delay in that was actually getting the telco cooperation from Airtel to get the short code set up and to give us access to that for the SMS gateway. The actual setting up of it on our side was quite quick. We have quite a few projects that are doing data collection through SMS portals, so we had a lot of that code ready to go. Our timeline for launching the dashboard, so we were in Freetown last week talking to partners, so now we're just finalizing who we're going to work with, and we really want to do this as a user-centered design process. So we are going to be working with the partners to really understand their needs, and it won't be a hard launch. It will phase it out. So we have parts of this now working and ready. So we want to just work with users, test it out early, get feedback, and keep building. As I said, the project ends in July. So by then we will have hopefully a fully functional platform.
And this might have been obvious, but could you elaborate on what the no sensitization comment was? Was that people calling in for more information?
Yeah, so that was actually people complaining that they'd been kept in their houses and the sensitization campaign hadn't come to them. So this was during the first lockdown. I
gotcha. No, thanks a lot. And could you say a word about how the mobilizers will work? Will they? Yeah, could you elaborate on that a tiny bit? I was curious.
Yeah, sure. So this is with we're planning on doing this with Goal, who have the social mobilizers, and they are using community leaders, and they now have a form so they run on Kobo and on paper, I think, and they have their questionnaires, and they have that system up and running. It's been running in Sierra Leone for a few months now. I can't give you too many details, and basically what we're trying to do is just pull their data and understand what they want to do from it. So they have a lot of free text data that they currently don't use, but would like to use, so that we're going to help them with that and really try and understand, okay, what can we do, some of the sentiment type analysis that World Food Programme are doing, as well as trying to do some of the categorization.
Super. I think there's just one last question in the chat about what happens after 644 ends, and then we'll probably move on to the next.
Yeah, so 644 is carrying on. OGI, that's actually owned by Open Government Initiative in Sierra Leone. We want to do the same thing with this platform. We don't want it to be IBM internal. We want it to be taken on and owned by partners who will be able to build it, use it, do whatever they want with it afterwards. Super. Well, thanks a lot. And it's great to see how the different kind of, directions of input and output complement each other. And I think, if I recall right, the Jean Martin from World Food Programme also mentioned working with HDX. So it's nice to see that emerging as kind of a place to pool open data. Yeah. Great. Thanks a lot. I think we're up to the last presentation by IntraHealth.
Yeah, so our final presenter is Amanda from IntraHealth, and she's the International Technical Advisor for HRH and Knowledge Management and serves as the MHERO Global Coordinator, working with local and international stakeholders to support the MHERO platform in West Africa. Amanda also represents IntraHealth in the K4Health project, bringing a health workforce lens to the Global Knowledge Management project.
Just one moment, try and pull this slide up. And I'll unmute you. Great.
Hi, can everyone hear me?
We can. Yes, great.
Great. Good day, everyone. So are you guys going to do the slides, or do you want me to do it?
Because we aren't able to go in presentation mode, we were going to do the slides.
we'll be a little creative when we get to one section, but let's.
Exactly, yeah.
All right, let's get going. So thanks everyone for sitting through all of our great presenters, and I appreciate Dimagi for setting up this webinar. So we can go to the next slide. I'm going to talk to you today about mHero. mHero is a two-way communication system where Ministry of Health can send SMS to health workers. So mHero uses data from IRIS so that the Ministry of Health can send those SMS text messages to health workers' own mobile phones. IRIS is a health worker information system that was developed by IntraHealth, and it allows you to select who you want to send messages to, so you can select by cadre or location and really be specific about contacting your frontline health workers. mHero works on a talk and text phone as well as smartphones. The system allows health workers to message back, so this helps the Ministry of Health to better communicate with their health workforce. We've worked with UNICEF to create mHero, and UNICEF negotiated with the mobile network operators in countries where mHero has been deployed. So there is no cost to the health worker when they send a text message back to the Ministry of Health. The Ministry of Health determines what messages or use cases they want to send and to whom. As I said, they can select the IRIS who they want to send it to. The Ministry of Health develops all of the content of the messages and the workflows, tests them out before they send them, and then they take the data, analyze it. Just to back up a bit, mHero was established to build on existing systems, including DHIS2, IRIS, RapidPro, and ComCare. As you know, someone mentioned before, during an emergency response, it's really easier to build on what's already there as opposed to introducing something new. mHero harnesses the power of interoperability of all of these systems, strengthening health information systems where mHero has been deployed. So that's a very high-level overview of how the system works and what it does, and I'm really trying to paint the picture that the Ministry of Health is very much in the driver's seat of implementing mHero. We can go to the next slide. So IntraHealth and UNICEF established mHero during the Ebola response, and we wanted to help improve communication between the Ministry of Health and frontline health workers. So this slide illustrates the types of questions that would go back and forth from the system to the health worker, so that information about what was going on in the Ebola response could be quickly captured at the Ministry of Health level, and then they could respond. You go to the next slide. This is where we're going to have a little bit of fun. Oh, it's all there. Okay. I guess if you're not in presentation mode, the way this normally works is it kind of highlights step by step, but we can tell the story by looking at the slide of how the technology works. So mHero takes information from IRIS, as I said, which is the bottom left. And this is where we can get health worker information, such as the health worker cadre or their location. So say the Ministry of Health wants to send a message to all health workers at one facility or all of the nurses in one county. IRIS would be able to disaggregate that information. We also are interoperable with DHIS2 to ensure that the facility data is linked up. So the information that we're sending to all of those health workers at one facility that we pull from IRIS, that facility that information is also in DHIS2, and it is matching. So mHero goes through the health worker registry, which many of you know about through the Open E3 initiative. And then through this fun interoperability layer, it all comes together and then goes to RapidPro or ComCare, whichever SMS platform you're using. So this is where the messages and the content can be developed. We've been using RapidPro so far in our implementation of mHero. And the way the messages are developed, it's really quite simple. And we've been using very simple workflows. There's nothing too complex. So the information trees that are built in there are pretty simple. We always test them before they send them, but when we do, they go straight out to the health workers. So you can see our health worker images there. And then the data is flowing in two ways. So we have data flowing out to the health workers, and then they're sending us information so it comes back to the Ministry of Health. And we're working to ensure that the information that comes back through Rapid Pro, back through that interoperability layer, back through the health worker registry, can be updated into IRIS and DHIS2 as needed. Okay, next slide. So I want to talk a little bit about what we've been doing and implementing MHERO. We piloted MHERO in Liberia in November 2004. We got some funding from UNICEF, from USAID through the K for Health project, and also a little bit of money from Johnson & Johnson to scale up in Guinea. But our initial pilot with MHERO was to look at the health workers and validate, are those health workers there? There was a lot of movement of health workers with the Ebola outbreak, going to Ebola treatment units, leaving service, and even many, unfortunately, who died. So we did a validation use case to map out who was at what facility and what facilities were still open. The Ministry of Health quickly adopted this and was very supportive of this. And since then, MHERO has continued to grow at the Ministry of Health in Liberia. They've done lots of different use cases, all determined by them. This includes nutrition use cases, mental health use cases, measure evaluation, even used MHERO when they were supporting the Ministry of Health in an ICT assessment. We're also planning to scale MHERO in Guinea and Sierra Leone in early 2016. We've been doing a lot of work in Guinea, in particular, in setting up IRIS, which they did not have prior to the Ebola outbreak, but really wanted. So this has become a high priority for them because they're realizing the importance of knowing who their health workers are and where they are. So IntraHealth is working with a lot of local stakeholders to scale up their IRIS and build that capacity at the Ministry of Health to use IRIS. We're also working in Sierra Leone to scale the IRIS, working with the WHO. Currently, IRIS in Sierra Leone is only in the western region, so we'll be scaling it up nationally. And along with all of our plans to scale IRIS, we're talking about MHERO implementation. Many of the ministries of health or stakeholders in the ministries of health in Guinea and Sierra Leone want to do that health worker validation exercise, like we did in Liberia with MHERO. And there's also some talk of doing some maternal and child health use cases in Guinea. We have a lot of things that we're planning next, and I do want to say that we have received funding from the USAID Grand Challenge, which is affording us the ability to scale in Guinea, Sierra Leone, and continue to scale in Liberia. And we're also doing a lot of other things to improve the back end of the technology through the Grand Challenge. So we're improving the analytics platform. We're working with stakeholders to improve data use so that the information they get back, it comes back in a way that they are able to analyze and use. We're working on interoperability with other systems, such as ComCare. We're also going to be launching a virtual learning course next year. So this is something that we're designing with WAHO, as well as other ministries of health who are using MHERO, to bring users together in a way to learn online what works best for them, what would they like to see, and do a little bit of online learning together and sharing of information. I don't have a slide here, but I think it is worth mentioning a couple of the challenges that we have faced in implementing MHERO, and a lot of them have already been discussed in this webinar, so I'll just echo the ICT infrastructure, particularly in the rural areas, has been a challenge. A lot of the SMS that are sent out may not make it, or there may not be a response because of the connectivity in the rural areas. The infrastructure at many of the ministries of health has also been a big challenge. Server capacity, network capacity, computers, particularly in Guinea, has been a really big challenge, as well as the capacity of the staff to manage setting up use cases and even using IRIS to export the data they need. That's been a challenge. The availability of those staff, too, is a challenge. They have many things to do, and particularly with the Ebola response, there have been many demands on staff at the Ministry of Health. And though we're using systems that many of them already know, it's still an extra step, an extra layer of work. I would also say that the governance of data has been a problem or a challenge. Many ministries of health don't have strategies or policies on data and data security and data governance. And so that's something I know has been discussed with many partners, but it is something to be aware of as a challenge. Okay, next step. So I just want to conclude by highlighting some of the benefits of MHeroes, and I can't say enough about how the fact that MHero is really driven by the ministries of health is a benefit. We talked about user-centered design, and I think this is quintessential user-centered design. Everything that we're doing with implementing MHero, with the analytics, even by having the virtual course that we're planning, we want the users to tell us how we should be improving the platform for them and how the platform should be for them. I haven't mentioned much about the health workers, but MHero does make them feel more involved and motivated. We've certainly found that, and I think someone else mentioned that earlier in one of their presentations about how engagement with health workers and community motivates them. And finally, facilitating health system strengthening. We're looking at how all of this data comes together and connecting ministries with their health workers in ways they've never been connected before really does strengthen that overall system. And not only for Ebola, but for, way beyond Ebola and the recovery and having a more robust system in the future. I think MHero is a platform that is really beneficial for facilitating that. So the last slide is a picture of a lot of logos, and you can go there. And this is just to highlight some of our many partners that we've been working with through our implementation of MHero. We're very transparent and collaborative and working in the Ebola outbreak countries and even beyond. We are going to be working in Mali soon to do IDSR for using MHero for IDSR. So that's all for now. I don't know if anyone has any questions. I haven't seen any in the chat box yet.
Oops. Oh, thanks, Amanda. I think it was a great last presentation to end, and a great last slide to end on, to show kind of the power of collaboration and of interoperability. I think you brought a lot of the themes together. I'm curious if you have a sense, if you have data from the response rates of the from health workers, and I'm curious how it seems like there'd be an obvious problem of the validation exercise that you ask, are you there, and you get no response, and how do you distinguish they're there but didn't respond from they're not there? I'm curious it seems like a real problem, but I'm curious how you all dealt with that.
That's a really good question. So our pilot in Liberia, we targeted 4 facilities in 4 different counties. And I would say that our response rate was okay for a new platform. And we've been finding that with a lot of our different use cases that we've been implementing. A lot of what we're doing is doing awareness raising with different units in the Ministry of Health so they know what MHero is and how they can use it, and doing a lot of training. And some of that's caught on. I mentioned the mental health unit had no information at all, because nothing is captured in DHIS2 about the mental health services provided to their health workforce. And so they used MHero to just find out what, sort of cases are they seeing and what support do they need. And that was a new way for them to get information that they weren't able to get before. As far as validating health workers that didn't respond, I'll have to get back to you on that. I'm not sure how the team used that or dealt with that challenge, but it's a very good question.
Sure. That seems like a toughie. And there is a question in the chat about whether you brought together all the health workers in the system. Were there health workers who aren't registered in IRIS, and how was that handled?
That's a really good question. So for right now, we're just using IRIS, and so public sector paid health workers are those that are counted in IRIS in Liberia. There have been a lot of talk about getting community health workers, tracking them and putting them into IRIS in different countries, but that's not where we are now or for the private sector. I see a question about what kind of responses do we get from health workers. The questions that we ask are meant to be quite simple, because asking complex questions, as someone said earlier, is very hard to do through SMS. So a lot of them are yes or no responses, and then a couple of them are open-ended responses. So we may say, are you, do you have enough supplies, that was in the example, yes or no. Do you need more, yes or no? And then the Ministry of Health can follow up, more concretely with a health facility manager about what might be needed. So hopefully that's a good enough answer about the kind of responses. As we do more use cases and workflows with MHERO, we'll be able, and people get more used to it, they'll be able to do a little bit more in-depth responses. And we'd also like to eventually add IVR into it. This is why I was asking a couple of questions earlier about IVR, more as a way to share information probably than get a lot back, because it is hard to capture data and do data collection through IVR. But it is a really good way to send out message blasts or information to a large cohort of people, especially if we do community health workers where literacy might be a problem on SMS.
Super, thanks a lot. And perhaps as a segue into the closing section, I have one, you touched upon data governance and interoperability, and I wonder, it's very easy to talk about us all sharing our systems. I think you all have a lot of experience. I wonder if you might, share some of the kind of key next steps for us to really share our data effectively and achieve the goals of interoperability. In the coming, there's a lot of efforts underway, like the USAID, BAA, and stuff. And what do you see as some of the priorities for making that real?
Well, that's a huge question, and I'm really happy to see the transparency in which so many partners have been working under the Ebola response, and thanks to USAID, particularly the Global Development Lab, for setting up the calls every Friday so we have a chance to share challenges and talk about what we're doing. And I think we just need to keep doing that and not be scared to share information, even if it's something that doesn't work. It's really important for us to say, this didn't work and this is why. And this webinar has been an excellent platform for many of us to talk about that. And we've got to keep doing that and find ways to, coagulate all of those lessons learned and document them and be sure that other partners that are working in this domain, that may not be on this webinar or may not be on a USAID call are aware of this. So we're not repeating things over and over that aren't working well. I think the things that we do need to focus on are in addition to transparency, are the system interoperability, because that's where the data lives. And in order to really have a holistic picture of what's going on in a country, making those systems work together, and it is going to take a lot of time, and it's going to take a lot of discussions and meetings and whatnot, and we need to be sure to include our Ministry of Health stakeholders and in-country stakeholders in those discussions, because at the end of the day, all of this is their data and their systems, and we just need to do what we need to do on our end to make sure that it is working for them.
Well, that was a great response to a big question, and you really hit on some great elements. So I think we're now going to officially finish this session and go to the ending session, which might just be a few minutes or longer, depending on how much people have to say. We've changed the rules of Zoom, so now you can unmute yourself, and so it's a free for all. And I'll just invite people to see if they have any kind of closing comments or reflections or open questions that haven't got answered yet. And feel free or to type things into the chat window if that's easier. Just to kick it off, I mean, I think it's like a general takeaway at a high level from all this is it seems like lots of progress made, lots left to do, and I'm certainly encouraged. It feels like we've made progress that will enable us to do better on future emergencies. And in a way, I think the fact that this crisis was kind of a long one allowed for more of that kind of iteration than some of the other crises that we've been more on the sidelines from. So it seems like we're in better shape, though it seems like a lot of the same challenges, connectivity, new systems, having to, will still be constant when we're trying to address future emergencies. So both, somewhat optimistic, somewhat daunted from this, but it's been really great to see these different reflections and just how much our different systems complement each other. So that's it for me.
I know we had one question from earlier in the chat that we ran out of time. And Meenal, I wonder if that's still a question that you'd be interested in posing to the group?
Karina, which question that was?
Let me see. And just to reiterate, because we changed the settings, previously you could not unmute yourself. If you'd like to ask a question, you can just click on the microphone in the bar at the bottom to unmute yourself. If anybody has any questions to ask, I will scroll back up in the chat. I think we had one more, maybe during Paul's presentation when we got sort of to the end of time.
Hi, this is Meenal.
Hi, Meenal.
Can you hear me? Hi, so the question I had was about how, I think somebody was talking about how it was a very international team from the tech development side. So it was a broader question on how to ensure sustainability by including the local tech environment. And this is something that we're thinking about as well. How do you make sure you have local developers, local tech folks who would be able to carry on and make sure that the system, you know, there's not a small breakage and then it stops being used?
I think the question you were asking was in reference to maybe some of the MercyCorps tech tools.
Yeah.
To be honest, and this is something that I know MercyCorps has discussed quite a bit with John Hopkins' HC3 program here in Liberia, but a lot of the information we were collecting and engaging with during the course of the outbreak has sort of lost its relevance, not so much now with the new cases, but it's hard to keep it going. I think a lot of the data we were collecting was the outbreak specific, and as the outbreak becomes, I guess, less of an issue, then some of the data isn't as useful anymore. The one thing that I would say is that what we have found is that you know, I feel like we're 5 steps ahead of the government, and so it's very hard to get the government on board because they're not really at the level that we are at. And I know this is something HC3 here in Liberia have been working on quite a bit, so maybe Elizabeth might want to talk about
that. Thanks a lot. And I'll give another second if people want to chime in on that important point.
This is Adele. Can you all hear me?
Yes.
Yep.
Hi, everyone. So I had a related question, which is that we hear a lot across all of these different projects and others that one of the big challenges is that there's not the national capacity. Sometimes this is around technical skills. Sometimes it's around being empowered to make decisions rapidly based on information coming in. And I'm curious if any of you are aware or if any of your projects have engaged in any kind of effort to build that capacity and overall thoughts on where to go from here, because it seems like what's happening is that people are looking at sustainability of technologies and projects related to their particular areas of work, but I'm just curious if there's a broader effort to address this underlying gap.
That's a great question, and I think so. I'll say for Dimagi's case, we're certainly interested, on the particular thing of building capacity to use our tools. We're training everybody we can to be able to configure and deploy their own mobile apps with our ComCare platform, and that's obviously just one little piece of the puzzle. But definitely agree, and it's I think it's very hard to build that capacity during a crisis. So it's a better time to do it when you're in less of a crisis mode.
Maybe also to answer that question, Adele, is so for our program, we engaged all these local NGOs, and at the start, obviously during most of the emergency period, they just sort of were collecting data, but they couldn't actually code the surveys and things that we use through ONA and ODK. As the program wound to an end, we handed over all the electronic devices to all the local NGOs, and a lot of them have been working with me and my team, not on any official basis, but on an unofficial basis, and we've been training them to do the coding and giving advice and guidance on how to do that. But that's just not with the national government level, but that's with local NGOs and local staff here, with the idea being that as local NGOs start to play a bigger role here, they can set up their own monitoring and evaluation systems and data collection systems using technology.
Hi, Adele. This is Amanda. With MHERO in Liberia, we've trained several staff that were sort of volunteers at the Ministry of Health in a sense, and very low level, but we've taught them how to do all of the development of the workflows and use cases in RapidPro, and they are part of the MHERO team there. We pay them a low stipend, and the goal and the intent is for the Ministry of Health to continue paying them after the end of our award. But I think bigger term, we can work with, sort of task shifting of ICT in a way and work with local NGOs. But I do think we need to look at how we're training people and work on mentoring and twinning for ICT and informatics with health training institutions across sub-Saharan Africa, because we really need to have more of a pool of people that we can work with and train so that we, as this field continues to grow, which undoubtedly it will, we'll have more people that we can work with.
Super. I think another encouraging thing is a lot of stuff is I'd say trending in the right direction. You know, connectivity is maybe not getting better as fast as we'd like, but getting better. Our tools are all getting easier to use. And general capacity is generally and interest is growing. So that's also a promising sign. Super. And it sounds. If anybody else has a last closing thought, now would be a good time to say it. Otherwise, I think we could just end with gratitude to all the presenters who put in the time to be here and shared their thoughts. We really appreciated the candid and open reflection, both on what worked and didn't, and I'll say thanks to all the Dimagi team who put this together. It's really it's been these kind of events I think are really just crucial for us to stay in touch and be able to work effectively in the future. Thanks everybody.
Thank you very much.
Bye. Thanks, everyone. We'll also be sending out a recording for this, so if you'd like to filter that. And there's also some follow-up information policy that you want to share on that assessment. So I will help facilitate that and talk soon. Thanks so much.
Thank you for organizing this. Thanks a lot. Bye-bye.
Thank
Bye.
you.
Thank
Bye.
you.
Thanks, everyone.